Good afternoon, everybody. Welcome to our grand rounds. This is our first session on psychotic disorders. We have another session um, in a couple months, and we are fortunate to have Javier Ortiz, who is an assistant professor of psychiatry here in our department. He gave grand rounds last year. Um, and Dr. Ortiz joined us about 2 years ago. Is that right, Javier? Yeah, and he came from Yale. Dr. Ortiz graduated from medical school at the University of Guadalajara in Mexico. And after that, he did his residency at the Mayo Clinic in Minnesota. While he was there, he worked for several years with Dr. Fry, the chair of psychiatry, who's an expert in bipolar disorder and first episode psychosis. And Dr. Ortiz was really a critical person in developing a database that focused an epidemiological database on several counties in Minnesota, keeping track of all patients with first episode psychosis for several years, their hospitalizations, their treatments, their legal events, things like that. And this database he has examined with Dr. Fry over the last several years, and he will continue to examine to look at some of the characteristics of this very interesting population. Consistent with that, work during his residency. He chose to go to Yale to work in the public psychiatry first episode program. He was there for a year, and then he joined us, and we were lucky enough to have him come and take over the leadership of our early program, which is our first episode clinic. So it is my privilege to introduce Dr. Ortiz, who will be talking about antipsychotic related weight gain in schizophrenia and metabolic complications. Go ahead, Dr. Ortiz.
Thank you so much, Dr. Castillo. Um, I'm going to talk about a problem that I think is relevant to all of us, which is weight gain in people taking antipsychotics, specifically in people with serious mental illness. And I hope that after this lecture, we can all kind of think about this more carefully and also be more empowered to criticize some of the data that we sometimes get fed kind of from research. So I titled my presentation Obesity and Antipsychotic-Induced Weight Gain in People with Serious Mental Illness. I have no conflicts of interest to disclose. And so I want to see if in the chat people can estimate how much obesity you all think that we have in the COPE clinic. I have the data that I'm going to present, but if people can estimate how many of the patients in the COPE clinic we like the people in the ground rounds thinks are have obesity, it will be interesting for me to hear what people estimate. Okay, we're in the 60s, 70s. Okay. Wow, so much. So everybody knows that this is a huge problem. The results that I'm showing here are the results from all of the patients. We saw 1,270 patients in COPE in 2025. And this is kind of how their BMI is distributed. And so we have that is a little below 50%. No, sorry, a little above 50%. No, a little below 50%. And if we will include the overweight, it will be almost 3/4 of the sample will be either overweight or obese. So it's a huge problem. And as psychiatrists, I believe that we are kind of we are the ones that use the most antipsychotics, and not many other specialties use antipsychotics. And I think that this problem is something that we are in some ways related to and causing. And so we This is a huge problem. I hope that the problem is there. How does this compare to other studies? This is a meta-analysis that shows that we are on par with what is estimated for the United States, with this meta-analysis showing that in the United States is between 41 to 50%. So we have kind of the similar rates of what is reported in the literature. So why does it happen? That's one of the objectives for today. Uh, and so the first question is there anything about schizophrenia that causes obesity, even outside of the antipsychotic treatment? And so this is a Chinese study that divided, it's a cohort that divided patients in their duration of untreated psychosis, duration here in the second line. So healthy controls, short duration of untreated psychosis, moderate duration, and long duration. And so as we can see, there is a trend that the longer the duration of untreated psychosis, the BMI increases. The glucose tolerance, the fasting blood glucose doesn't change as much, although a little bit, and they classify it as significant. So maybe just the illness in itself of schizophrenia is related to obesity. This is a different study. This is a meta-analysis of patients that are antipsychotic naive, and they tested their glucose tolerance test. And they also found that there's something in people with schizophrenia that increases their glucose tolerance. So even before the starting of antipsychotics, there seems to be a vulnerability for obesity in this population. So why does it happen? I think patients ask us this a lot. Do they ask, well, does it increase appetite? Yes, it definitely increases appetite. And it increases appetite in multiple ways. I think the classic board question is, which is the receptor associated with this? If that will be the question, I will respond that is the histaminergic receptor associated with obesity. But also the dopamine blockade alters reward systems and will cause these abnormal relationships with food and cigarettes, as we know that people are just really trying to just find something to experience a little bit of reward. Muscarinic also disrupts insulin homeostasis. I also have this theory, although it's not proven, that just high anticholinergic burden dries the mouth. And drying the mouth in this in here, people don't drink water, they drink soda. And so just drying the mouth and using soda, I wonder if it's related. There's a few studies on geriatric population on that might support that hypothesis. But that's not proven. It also affects the endocrine system. It affects like hormones like melatonin. It affects the microbiome. And so the pathways in which antipsychotics result in weight gain is via multiple pathways, and just resolving the kind of one receptor is not only resulting the result of obesity. I also think that dopamine blockade, especially at high doses, can be related to hypoactivity, decreased movement, and so that might also result in just a sedentary lifestyle. So which antipsychotic causes the most weight gain? This is a meta-analysis by Professor House and Cipriani. I think this is an answer that we all should be very familiar with, that clozapine is the antipsychotic that causes the most weight gain, followed by really the ones that we use, olanzapine, then quetiapine, and then so on, with Abilify, in this study, in haloperidol showing less, but my experience is that all antipsychotics cause weight gain. But there's definitely kind of a difference in how much they cause that. So clozapine the worst, ziprasidone the least in this study. So how does the weight gain evolve? I think this is very important because sometimes we wanna kind of start treating the weight gain after it happened, like 3 months after we started the antipsychotic. But in reality, as we see in this study, that this is a study in youth, the the weight gain is front loaded. For instance, in this study, the olanzapine, they gained 10 pounds in the first 4 weeks, then 4 more pounds in the following 4 weeks, and 4 more pounds. So at 12 weeks, they had gained 20 pounds, 10 kilograms, and that it's around 15% of their weight. I want you to keep this in mind because eventually I'm going to present the data on Lybalvi, which is olanzapine samidorphan, and how the data, you know, how the data might not be very reassuring given that the patients had already been exposed to the medications. Um, okay, so the point here is antipsychotics cause weight gain early, and then it kind of slows down over time. My impression is that if we were to follow them longer, it will eventually plateau at some point, and there will not be as much weight gain. So that's another question. Then the other question that we need to answer is that I ask my residents all the time. I said, I want to decrease the dose because they are gaining weight. And so that's a very important question for us as psychiatrists. Does antipsychotic weight gain is related to the dose, or is it a dose-independent side effect? The way the authors describe this is that every antipsychotic has its own signature. So as we can see here, Abilify at 10 milligrams, it has almost half or a little bit more probably than half of the weight gain that it is on kind of the FDA approved maximal dose. So if you're really wanting to decrease from 15 to 10, I don't know how much big of a deal. With Haldol, it really plateaus early on. So if you were decreasing from 15 to 10, you're not really making a big impact in that. This is based on multiple studies, and you can see big sample size over here at the top of the figures. Clozapine, as you can see in the clozapine, it's only based on one study, and you see the confidence intervals that they are huge. So, I cannot say with certainty if this is true, but at least in this study, there seems to be a linear relationship with weight gain. With olanzapine, really, as we can see, it is at 10 milligrams, almost everything, all of the dose, all of the weight gain is already happening at 10 milligrams. And if you increase, yes, there's a little bit more, but most of it happens in the first 10 milligrams. Risperidone plateaus, quetiapine plateaus. Okay, so that's kind of like every antipsychotic has its own signature, and we have to be familiar with that. Now, this is to me, very interesting finding that I kind of makes sense to me, and I tested it almost every day in my practice, that it is true. That is that when someone is gaining weight, they are getting better. I sometimes can see I plot, or I do the graph of their weights, and I see there's a weight loss, and I can say that's when they relapsed, when they were losing weight. Is that because something intrinsic to weight gain, or is that because adherence, that they are not adherents and they lose weight? I don't know. But if someone that is taking antipsychotics, especially kind of early on in treatment, is really not gaining any weight, and they are not getting better, that will be a suspicion that they are not taking their medicine. So this proves that this is a meta-analysis that I showed there earlier, that there's in the y-axis you see the weight, and in the x-axis you see kind of improvement in symptoms, and so there's kind of a linearity to it. Okay, so what do we do in the COPE clinic? I me, and when I go to residents, I always ask them, hey, like how's the patient's weight? How are the labs? I am very transparent with side effects, very transparent with the side effects, and sometimes this results in patient not wanting to take medications. I always assess for soda intake. I think it's kind of, I sometimes get impressed by how much soda a person can drink in a day. And my sense is that just that behavioral change might have the most impact and might be kind of the highest yield that I can do in a kind of busy psychiatric practice that we have. And I teach them a little bit about other kind of zero-calorie drinks. Sometimes they don't even know how to drink, how to read things, thinking that juice, well, I'm not gonna drink soda, but I'm gonna drink orange juice, or I'm gonna drink Gatorade because Gatorade seems to be healthy. And so really trying to teach people about reading labels and finding the zero calories, zero sugars. Um, Also assess for night syndrome. As I said, there's nothing really good happens when you open the fridge at 11 p.m. And so people, after taking their antipsychotics, they get hungry. And I also can confirm this because my wife was a nurse in a inpatient unit, and she will talk about the olanzapine munchies. You give the olanzapine at 8 p.m., and at 10 p.m., people are already asking for the snacks and a lot of snacks. And so trying to address kind of a healthy snacks will be, is something important to recommend any activity. And I gotta admit that sometimes, because I consistently talk about weight, sometimes it hasn't gone well for me. Sometimes I have been asked not to ask them anymore. Sometimes I have, just gotten bad feedback about kind of asking about weight and approaching weight. So I'm still also trying to find a way. My impression is that when I'm seeing my own patients is different than when I go with the residents, and I'm just getting with the resident patient for a little bit and ask them that. So I kind of have to stop doing that. Okay. So what do we know about treatments? We have still some time. So this very rare to have non-pharmacological psychiatric research published in the New England Journal of Medicine. This was published in 2013. This is a behavioral intervention that was done at 10 community centers, mostly in the East Coast. And they randomized around 300 people to either receive tailored group and individual weight management sessions and group exercise sessions versus nutrition and physical activity information, and they check their weights. So this is kind of the sample, around 45 years of age, obese, at a BMI of 36. Mostly, almost everybody was taking an antipsychotic. So 90% were taking an antipsychotics, with around 22% taking clozapine or olanzapine. The randomization worked well. And so this was the intervention. The goal was that they lose 10 pounds. They were also recommended not to exercise, to drink water, no sugary drinks, smart portions, no junk food. They had kind of events and groups so that they can come into the gym in the clinics, and they were educated. And so this was a 1.5 year trial, an 18 months trial. The table 3 is kind of the adherence to the model, to the treatment. And we see that initially there was some adherence. They offered 16 weight management sessions and they came to 10. By the second part of the year, they overall, let's go to the overall, they offered 164 sessions, and on average they went to 32. But they found that it works. It works, and compared to the control, the intervention group lost around 3 kilograms. Now, as we will see, 3 kilograms compared to the modern medications that we have, I don't know. I mean, I don't know if is this cost effective? I mean, they didn't do a cost effectiveness analysis, but imagine all of the investment that was done for these patients for 1.5 years to lose, 3 kilograms. So I don't know. I kind of put that question for everybody here. Um, what Dr. Lewis has, when I present this data, what Dr. Lewis has suggested is that maybe the trajectory is going down, and maybe the lessons, the behavioral intervention might carry it out into the future further. So I support obviously behavioral interventions. How much money, how effective they are, I think it's still up for the air. This is 2013. Just earlier this year, or 2025 November, there was another recent study on this. Veterans, BMI above 30, serious mental illness, and they have this app. I think this is a cheaper study kind of to develop, where it's called the Coach to Fit app. I'm going to show a little bit of their dashboard. They had weekly calls from a peer specialist, a fitness tracker, and a smartphone app that it will track them and comparison. This is a 6-month study. The main outcome that I'm going to be talking about here is weight, but kind of think of weight as a surrogate for cardiovascular mortality, diabetes. So this is kind of the dashboard that it will show them how many steps they've done, how is kind of like it will plot or it will graph their weight. It will tell them how are they doing with their learning modules. And so what they found in this study that was it was, again, only veterans, around 50 years old, with a wide range of diagnoses, but mostly depressive disorder without psychosis. And I think very important now that the GLP was equally distributed across the two groups. They found that at 6 months after this intervention, they lost 1.6 kilograms. Again, I don't know, doesn't sound much. That was the significant outcome, as well as the BMI. The other outcome, the 6-minute walk test, kind of that measures cardiovascular fitness, was not significant. So again, behavioral interventions work, but have modest effects. Regardless, the guideline still recommends that this should be our first-line interventions, and that we should kind of be advocating for exercise and nutritional interventions as the important one, and that we should focus on prevention of weight loss. Okay, so I'm going to talk about few pharmacological interventions. And so the ones that I always think is, you have someone on olanzapine, and are you going to switch to Abilify? What is the evidence for that? Or are you going to add metformin? Are you going to add topiramate, samidorphan? So anyway, that's kind of what we're showing. So the data on switching, this is a meta-analysis. There's 3 studies on switching that have assessed weight loss, and this is a switch to Abilify. A switch to Abilify from a second-generation antipsychotic seems to work for weight loss, seems to result in a mean difference here of around 5 pounds. 5 kilograms, sorry, it was in kilograms. So, pretty significant. Switching from an antipsychotic with a higher burden of metabolic symptoms to Abilify seems to be effective. And again, if you're switching from something else, from first generations or risperidone to olanzapine, you will get weight gain. This is kind of important. It's important to point out from this study that switching to aripiprazole was not associated with worsening of psychotic symptoms. I think that's kind of the idea here, or the message is that switching to Abilify seems to be safe and will improve weight, and might result in around 5 kilogram loss. That's a lot. Okay, so now metformin. Metformin is better in prevention of weight gain. It's not as good for weight loss treatment. This is the systematic review, kind of just to orient you to this table, are all of the studies that exist for this, all randomized trials. I think the important thing here is that the way metformin was prescribed and the type of population was a little bit different. So we have different antipsychotics and different doses of metformin. And so we'll see that there's some heterogeneity in the meta-analysis, but in general, metformin seems to be very effective for antipsychotic-induced weight gain prevention. And the weight is and the effects are more pronounced when you use them in children or first episode psychosis, as we see it in this study. So if we that take care of people with first episode psychosis, starting metformin early is a challenge because they don't want to take anything. We are really struggling to staying on the program, and so like now they take one medicine and you're adding a second or third medicine. It's sometimes not easy to get some people on metformin right away, but at least kind of the evidence is there and to support that, and the effects again more prominent in first episode. Now, just recently, last year or 2 years ago, or Schizophrenia Bulletin published the guidelines. The guidelines for using metformin as a prevention strategy is that if you're gonna start someone on olanzapine or clozapine, you start with metformin as well. Or if they have these risk factors, if you're starting quetiapine, paliperidone, or risperidone, and they have kind of already diabetes, prediabetes, they are young, or they have kind of a high BMI, it's like when you start the antipsychotic, you start metformin at the same time. Similarly, if you are getting weight gain, 3% of the weight gain as you start antipsychotic, you should also do it. They also mentioned the GLP-1s. I'll show the evidence of the GLP-1s in a second. This is how you should escalate metformin. Metformin, you have to worry about GI side effects mostly, that if you reassure them that it's going to be transient, I think for most people that are able to tolerate that. And the idea will be to titrate them to 2 grams a day in divided doses. So I hope, I hope we can kind of get a good practice of starting metformin in patients. And maybe the inpatient teams can support us with that. So now there's this study, the IMPACT trial, that tested these two things that I have talked about, whether to add metformin or to switch to an antipsychotic or to continue with the same antipsychotic. Big important trial. This is again in youth only. This is 8 to 19 years old. And so there is a 3-group study. Let's see. So very young population, we see 13 years of age. Mostly bipolar. This was done before DSM-5, so lots of bipolar in this sample. And high antipsychotic, but mostly Abilify. And again, just I don't think I mentioned that these are people that were gonna be exposed to antipsychotics that had already developed weight gain. And so you add metformin, you switch, or you continue with the same. And so, and the switch was mostly almost everybody switched to aripiprazole if they were not on aripiprazole. And so as we can see, the control continued to gain weight. At least this metric is just so challenging to kind of evaluate weight gain in children because they are growing. And so the way kind of that you adjust for that is that you do the BMI Z-score. And so we can see that the Z-score continued to increase slightly in the control group and decrease a little bit in the metformin and switch group, and they were not different between each other. As we can see here, I'm gonna just focus on weight. The control at week 24 gained 8.5 more pounds versus the metformin group that lost a little bit and the switch group that stayed basically the same. So, both options are reasonable and effective to add metformin or to switch to a different antipsychotic. And importantly, psychiatric symptoms at week 24 did not differ between the groups. So the Lybalvi, expensive medicine. This is the data that we have from randomized trials. I presented randomized trials first. There's 4 randomized trials. The first one is a phase 2. This is healthy controls, and it was superior, 2.2 versus 3.1, being superior to olanzapine alone. Seems is a low bar. I'm gonna say that it's a low bar. By kind of the 24th week trial, the longest trials, the Corel study that is now done in schizophrenia, the weight gain of patients on Lybalvi was 4.2 versus 6.59. Again, Lybalvi doesn't prevent weight gain in people taking olanzapine. It just makes it less bad. But again, that's a low bar. And so this is the results. There's 2 of the 3 studies that were done in schizophrenia were positive, and they got approved. And so I was not impressed by this data when I saw it. We still use it in our practice, and this is the 4-year open label study. Now, what I have not seen anybody discuss from this study is that these were people that were already enrolled after the initial phases, and as we saw in the data of what is the timeline of weight gain happens early on in treatment, and so these people had already gained weight, and then they are kind of enter the extension phase after being on different amount of time for the open label extension trial. And so what they show is that body weight at year 4 is kind of 2 kilograms, and I was like, okay, yeah, that's not bad at all. But how much did they gain before they enroll? They enter the open label phase. I don't know. So, anyways, that's kind of my skepticism a little bit about Lybalvi, especially. Well, no, not yet. Topiramate. Topiramate is also something that we use. I sometimes don't like it as much, obviously, because of the cognitive side effects. Now there's debate whether low doses of topiramate cause cognitive side effects. But topiramate seems to work as also for weight loss. We see it here. There seems to be some heterogeneity. I mean, there's a lot of heterogeneity in the study, but at least kind of the full meta-analysis and the evidence shows that I think it's a reasonable option for some of our patients if we want them to help them lose weight. And kind of psychopathology, this is psychopathology. Very interesting that kind of topiramate helps with psychopathology in these studies. We don't use it in kind of our practice here to manage symptoms of psychosis specifically. So now the Ozempic or the semaglutide, again, I don't have conflicts of interest with this. This is the Australia trial. The Australia trial recruited recruited people with schizophrenia that had been on clozapine for at least 18 weeks, that had a BMI above overweight, and they were kind of randomized to weekly semaglutide or weekly placebo injection, and they followed them over 36 weeks. Now, the trial ended up being stopped early, not because of the reasons you think, but it's because there was a shortage of Ozempic. There was no Ozempic, and Dr. Sinskid couldn't find more. The medicine, there was no access to the medicine, which I thought that was kind of unique. I never heard of that. And so anyways, people with schizophrenia, all on clozapine, be weight, they had a significant amount of weight, although this might sound a little bit different, the kilograms. And so look at that. I mean, this is a percentage of weight change. So around at 36 weeks, around 15% of the weight. So if we calculate 15% of the weight of 113 kilograms, that's like, I would say like 18 kilograms, just to kind of put it relative to the effects of the non-pharmacological interventions. So relatively well tolerated with the side effects that I'll talk a little bit about side effects of GLP-1s. And the newest one just published in JAMA. This is a Denmark trial. Is recruited patients that were on clozapine or olanzapine that already had shown some glycemic dysregulation, but were not on anti-diabetic therapy. Again, randomized to semaglutide or an injection a little shorter for 26 weeks. A little larger trial compared to the first trial, to the Australia trial. And so 36 patients all can have a psychotic diagnosis. And they found also a significant difference in weight. I think it was 9 kilogram difference on average for those taking Ozempic versus those taking placebo. So, with this, how much expensive? I know Ozempic is expensive, but is it more expensive than having gyms and hosting groups? I don't know. This is where I put it kind of relative, the non-pharmacological, the first two that have 3.2 kilograms each versus these effects. So just a few kind of practical things. New Mexico Medicaid, I accessed this website just a few days ago. New Mexico Medicaid does not cover GLP-1s. So, for weight loss, at least, if they might cover it for other indications, but not for weight loss per the website. Medicare covers them for people that have obesity and the following comorbidities. I wonder if the sleep doctors here know, are they using tirzepatide for obstructive sleep apnea, and they are getting it approved. But if you are ordering it, the study will say that in 80% of the cases, you're gonna have to complete a prior authorization. And so, kind of practical things that you have to absolutely know if you're gonna start someone on a GLP-1 is they should not have a history of medullary thyroid carcinoma or MEN2. That is absolutely an absolute contraindication. And you have to kind of counsel them about the GI side effects that they can get better, especially if you lower the titration. There's the dose escalation, how you should do that. And yeah, just one thing that I just saw today. This website called Trump RX has Ozempic now at $200. So I don't know. I mean, I'm gonna see if we can use it, but we'll see how this new kind of government medication thing is gonna happen. I don't know if anybody saw that too on the news. It just was released today. Anyways, I think that's all I have. Questions, thoughts?
Okay, thank you very much, Dr. Ortiz. So we have some time for questions. So I'll start with a question. So can you give us just a sense of what's the relative proportion of the variance in weight that can be attributed to having schizophrenia versus being on antipsychotics. So both of them, you make a good case with the literature that are predisposed to weight gain. Just can you give us a sense, more or less, how important is one versus the other?
I think almost 90% of the effect is driven by the antipsychotic. As we saw there's really very few studies that have addressed this. Um, but it was a Chinese cohort that showed just a few pounds or kilograms more with only 1 point BMI when we saw that weight gain can be pretty dramatic, especially in children. So I will say that most of the effect of weight gain is driven by the antipsychotic and very little by the condition, by schizophrenia.
Okay, thank you. Dr. Quinn.
Thank you. Thank you, Dr. Ortiz, for this terrific talk. It's always wonderful to hear about the, cutting edge work that's being done in our clinics and Cope Clinic under your leadership. So, I guess the question I have is GLP-1 agonists in some reports I saw were associated both with some positive psychiatric benefits as well as some negative psychiatric side effects, you know, increasing in depression or improvement in depression, things like that. Have there been studies in your population in patients with schizophrenia with psychotic disorders to show that there's any beneficial psychiatric effects of using GLP-1s besides the benefit for weight or metabolic syndrome?
So, the two studies that I know were the two randomized studies and important studies are the two that I presented. One published in Lancet, the Australian one, and the Denmark one. My recollection of the kind of psychopathology measures was that they remained stable and there was no difference in psychopathology measures. My also recollection of the big kind of suicidality association, it has been debated whether the suicidality there's signal whether GLP-1s cause or are associated with suicidality.
All right.
Great, thank you.
Dr. Toen?
Dr. Ortiz, terrific presentation. Congratulations, not only in the delivery, but also in the very thoughtful review of the literature. Congratulations.
Thanks.
So you're leading the first episode, the early clinic, and doing a great job. In terms of guidelines, to what extent have we moved to guidelines in terms of metformin, or for those who can get the GLPs, and maybe could be in some drugs or no others, including aripiprazole, which is for long it's been the number one recommended medication for first steps of psychosis, and actually what separates it from risperidone is actually the lack of weight gain. So to what extent should we do it at guidelines? And this is actually an area that you should be leading nationally in terms of guidelines with the Navigate and others, and to what extent has Navigate, folks, is the national project in terms of guidelines with first steps of psychosis. Should we, or should you rather, propose that it'll be started with Navigate? Dr. Ortiz.
I think we completed the Navigate training under Dr. Delbert, and yeah, I didn't think we got as much guidance with that. Really, my interest with this came from my training in Connecticut with Dr. Sentek. He's an obesity expert too. I mean, we all can get board certified as to become obesity physicians if you just take kind of the CME courses. So yeah, I think important recommendations kind of for everybody here, that I think one of the first evidence-based recommendations in all psychiatry was that at least for first episode psychosis, this is a board recommendation. We don't use olanzapine. And
Please,
Laura?
turn off your audios.
And a preference to Abilify. the challenge and the guidelines that were not developed specifically for first episode are that we should be thinking very early, even as we are starting, or if we are thinking that there's risk on starting metformin. So yeah, I think that's kind of where we are at. I would like to eventually kind of the COPE data, just a prevalence data of how much weight gain are people experiencing. I mean, it will be very nice to. That's why I had, like, if any of the residents wants to kind of do a descriptive study of kind of for population, New Mexicans, there's no one doing New Mexico, and it will not be as complex
Yes,
of a
sir.
study.
That was the 19. Yeah.
Okay. Let's see. Any other questions?
Let me do a follow-up,
Sure.
Dr. Bustillo. So again, our aripiprazole was superior to risperidone
Yes.
in tolerance, especially the weight gain. So then if our aripiprazole, that would be the first choice. For some reason, we have to move to a second choice. Right now, I'm focusing on first episode psychosis. Would you recommend that even if it's risperidone, of course, with olanzapine, we should start them either on metformin or GLP. But other than aripiprazole, would you recommend early on to be on? And of course, preventive medicine is better than anything else. So what's your recommendation? And also, should we consider instituting it locally in our early clinic, Dr. Ortiz?
There was a little kind of glitch in my connection, so I didn't grab all of the question.
Yeah. So first choice is aripiprazole.
Yes.
Because of the lack of, or the small amount of weight gain.
Yes.
But once, for whatever reason, we move to the second choice, let's say it's risperidone. Do you think, again, in first episode psychosis, effective or non-effective, early on, we should start in metformin or
Yes.
GLP? Okay.
Metformin. I mean, at least if you are preventing, if the weight gain has already happened, the evidence is less kind of impactful, or the effect size is less. But if you want to prevent it, that's kind of where the money is at. But again, the clinical challenge is that you are starting so many, all of a sudden you have these people in so many medicines, or there's all of these things, and the people might not want to do that. That has been kind of the barrier for me to start metformin.
Yeah, but I guess primo non nocere,
Yes.
don't cause harm. So then the other issue is that you mentioned that it appears that the weight gain is going to plateau.
Yes.
So in the studies that were done with olanzapine, initially that was the hope, and the plateau never happened. It never happened. So the longer the patients were followed, the larger the weight. The slope was smaller. So you could argue that in now focusing on multiple episodes, that anybody on weight gaining drugs should be on metformin, because again, since the slope doesn't happen or the plateauing never happens, that might be something to recommend. Your thoughts?
Yeah, definitely. Clozapine also has a similar trajectory of weight gain. Yeah, the slope definitely decreases. There's still some weight gain, but you never hit a ceiling. Yeah, so if someone is in PS today, they're gonna see like a case that because of Abilify, it was just going through the roof too, and they stop. The people don't like to gain weight. I mean, you are putting someone, a 20-year-old that is starting an antipsychotic, and then in a few months they have gained 20, 30 pounds. Their weight, their body changes dramatically, and they stop the medicine. And so this is such a critical problem that we all should be very mindful and don't lose attention to this.
I agree, and again, congratulations, Dr. Ortiz.
Any other questions? I see on the chat, Dr. Rose, it brings up, what about, switching to Cobenfy? What do you think when someone who's gaining weight, let's say on Abilify, Dr. Ortiz, what do you think?
Yeah. No conflicts of interest with Cobenfy, but I think that will be very reasonable. we are starting to get familiar with Cobenfy, and seems, my last patient, actually, that was the situation right now, and we're able to tolerate a transition. I don't think there's evidence to suggest that, like, unless Dr. Rose, you might know better. But yeah.
So yeah, I think that's it's important because we're talking about adding another medicine early on, yeah, especially in patients very early in the illness. So adding metformin or adding GLP-1s, and I can't emphasize enough something you've said, Dr. Ortiz, is these patients don't want to take any medicine. They do not want to take any medicine, and so I think we should really reconsider instead of adding switching. Although the data that you presented, switching worked as well as adding,
Mm-hmm.
but the practical problem of compliance is such that if we have medications like Cobenfy or like lumateperone that have shown themselves, it's early on. These are not huge studies, but the open label long-term follow-ups in these drugs do show that they behave like placebo in terms of weight gain.
Am I still
All
there?
right. Huh? Yeah, that's all I wanted. I wanted to say. I mean, what do you think about switching versus just adding early on?
I think using switching from an antipsychotic with a high metabolic burden to Abilify, very reasonable. If anybody wants to look into the literature on switching, you can abruptly switch. You can do abrupt switches for most antipsychotics safely, and doesn't seem to cause worsening of psychopathology in most cases. So I think switching to Abilify if they are on a high burden of antipsychotics, but like Dr. Kilgore asked, what if they are already on Abilify? I think really our option is, most likely will probably be Cobenfy.
Yeah, it should be switching again to
It should be switching
Cobenfy
again to Cobenfy, or lumateperone, yeah.
or
But there's no
lumateperone.
data for that. There's definitely
Yes.
no data for that. The
Uh,
I saw a question regarding nutrition plan. It could, I would love to, that's kind of, at some point, I was hoping to embed a nutritionist within the Cope clinic. Maybe it's challenging to get a nutrition consult. Maybe you know better, Dr. Pence, that if it's easy, but they also don't want to go. I would love to have a nutritionist within the early program that to help us with this. But as we saw, nutrition, all of these efforts that were put on non-behavioral interventions were not, or non-pharmacological interventions, sorry, were just tiny effects.
yeah. All right.
That's
Well, I think we should stop right now to give you a few minutes to go to your next appointment. I want to thank Dr. Ortiz and thank everybody for joining us, and we'll see you again next week.